Good afternoon, everyone, and welcome to webinar 3 in our series on strengthening commodity ecosystems for maternal and newborn health. This webinar is part of the Every Woman, Every Newborn, Everywhere series. We call it EWENE, and is organized by the Concept Foundation and Unitaid. You will be hearing a little bit more about EWENE from our keynote speaker at the introduction. I am Spring Gombe. I will be moderating today's session, which is on procuring for impact, value-based approaches for maternal and newborn health products. Before I get into it, some housekeeping. First of all, as you will have heard, this webinar will be recorded. We are offering interpretation into and from the French. To access that interpretation, please click on the globe icon on your screen and then follow to interpretation. If you would wish to use closed captioning, you also have the opportunity to do so, keeping in mind that it may not be entirely accurate as it adjusts to our different accents and ways of speaking. We have a question and answer function, which will be enabled, and into which we invite you to please put your questions or comments so that you are in communication with our expert panelists. If you have any technical issues, please also use the chat function to share these with the organizing team, and they will attend to them and respond to you directly. In the interests of time, we have put the slides into the chat as well, and you can follow those from the chat function. In the slide deck, you will find introductions to our speakers, including their biographies. We will deal with any questions that have been posed to our panelists or speakers in the final segment of the webinar. And we may group questions that are similar into a single question to pose to the panelists. So please don't be surprised if we don't hear your question quoted word for word. To open, I am very pleased to invite Jeffrey Smith, who is the Health Products Working Group co-chair of EWENE, to set the scene on the series and why procurement is central to stronger maternal and newborn health commodity ecosystems. Jeff, over to you.
Thank you, Spring, and good morning, good afternoon, and good evening to everybody who has joined us today. As Spring said, I'm Jeffrey Smith. I work with Unitaid, and I'm the co-chair of the EWENE Health Products Working Group, together with colleagues from WHO, UNICEF, and UNFPA. The Health Products Working Group has organized this webinar series in an effort to help us tackle the challenges of access to critical commodities for maternal and newborn health. The challenge that we face in ensuring consistent access to high-quality commodities is that very often in countries around the world, we don't have consistent access because of the complexity of the product access ecosystem. And that ecosystem is overall very fragmented. Unfortunately, there are multiple different actors who are working and doing great work, but we don't always align and coordinate that work. And so the intention, the purpose of this series of webinars is to help us overcome that fragmentation and build a more cohesive ecosystem. We believe that collaboration and collective action within the partners and across the different domains of the ecosystem will really help deliver greater access and more consistent availability of products for women and newborns. So this webinar series is helping us to build a common language and a common vision of what good looks like. What does a good, healthy, resilient product access ecosystem look like in all of its dimensions, from manufacturing to finance to procurement and beyond? Today's webinar is really focusing on procurement and what the different approaches for improving the procurement systems at national level can be, and why it's important for us to work together, not only as a number of different actors, but across countries in order to drive improved procurement system. We hope that this webinar series will help lead us to improved coordination, increase in resources so that we can better finance the commodities that are needed, and help us build the capacity to think comprehensively and collectively in order to strengthen product access. So through this webinar series, I strongly believe that if we come together and we align in our thinking and we build a common vision of what good looks like, we will achieve more and more consistent access to commodities. We have some excellent speakers today, and I'm sure we're going to be really strengthened by what we hear. Many of you are also aware that at the upcoming International Maternal Newborn Health Conference that will be held next month in Nairobi, the EWENE Health Partnership will be hosting a Monday pre-Congress symposium on the product access ecosystem. And we'll send more information about that in coming days and weeks. So thank you, Spring, and I'm looking forward to a really robust and exciting conversation.
Thank you very much, Jeff. And as we attempt to move towards this common language and common vision to think comprehensively and collectively, we've been posing questions to you as our audience about where we are. Before this webinar, we asked you two. First, what currently drives procurement decisions for maternal and newborn health products where you sit? And you will see that you have said such things as availability, low cost, price, funding, donors, value for money, and need. We also asked you what should guide procurement decisions in the future. And here you see needs assessment, again, quality of products, impact, forecasting, cost effectiveness, and equity. As you can see, the drivers cluster around the questions of price pressure, lead times, and financing constraints. And the future we're striving towards is emphasizing quality assurance, reliability, transparency, and outcomes. And so to help us to explore from how we get to there from here, we have invited Rachel Msimuko, who is the Supply and Planning Director at the Zambia Medicines and Medical Supplies Agency, also called ZAMSA. Rachel will walk us through the national procurement considerations from the Zambian perspectives and give her expertise on how we get to the markets and the access that we want through strengthening of forecasting and estimating needs. Rachel, over to you.
Thank you, Spring, and greetings to everyone. I'm very happy to be here to speak on a very important topic that is very instrumental in safeguarding the lives of every woman, every newborn, everywhere. And that will help us secure consistent, quality assured maternal and newborn health products to in the places that they are needed at the time that they are needed. So when procurement decisions focus on the value, that is value-based procurement, rather than price alone, they actively contribute to better health outcomes for women and newborns. And now, why does procurement matter for our mothers and our newborns? We understand that M&H outcomes depend on a reliable access to essential health products such as uterotonics, antibiotics, contraceptives, and neonatal supplies. And when they are not there, they directly undermine the quality of care and survival. Procurement decisions therefore shape availability, affordability, equity, and continuity of care, especially for the vulnerable populations. So what approaches have been used in public health procurement? Traditionally, focus of public health procurement has been on the lowest priced, technically compliant bid. So whatever bid is technically sound, is meeting our expectations, but is the lowest cost. So while this approach ensures cost control, it can be limiting for maternal and newborn health commodities because we need reliability and quality, and these are very critical. And so when we talk about base value, we're trying to look at approaches that look at framework agreement, and strategic sourcing, which allow buyers to consider supplier performance, sustainability, and supply continuity. So diving into value-based procurement, what do we mean by value-based procurement? Value-based procurement looks beyond just the price of the commodity to the total value in the supply chain. So it will integrate the cost of the commodity, the quality of the commodity, the reliability of the sourcing, as well as the health outcomes at the end of the day, which is the having the life-saving commodities available for mothers and newborns. So in looking at the cost and quality assurance for maternal and newborn products, for M&H commodities, quality assurance is, I think for the participants that we have in the webinar, most of you involved in the supply chain, some of you are providers, and for a lot of us, mothers as well, and have families. Quality assurance is non-negotiable. It is non-negotiable. Substandard products pose serious clinical risks to mothers and newborns. So while affordability remains important, value-based procurement ensures that cost savings are not achieved at the expense of safety, efficacy, or trust in the health system. So when we're trying to achieve value-based procurement, how do we get value-based procurement whilst also understanding our funding environment where the fiscal space is getting smaller and smaller and the demands are getting larger and larger? So one practical model is that of pooled procurement. So pooled procurement is where demand is aggregated for M&H commodities across programs. And an example would be most countries have a centralized medical store, and instead of each and every health center, health facility, hospital procuring the M&H commodities that they need in different procurement processes, those are aggregated centrally. So the demand is aggregated at the central level. So you're getting better negotiating power as you aggregate the demand. And this can be just within the country or even across countries. And as we have negotiating power, prices may be stabilized and we can secure access to quality assured M&H products while reducing supply risks as well as transaction costs. Jeff usually highlights the fact that even as we look at the health outcomes, we have to understand the entire system. So even as we're focusing on value-based procurement, what are the things that impact value-based procurement? And one of the bigger significant ones is forecasting challenges. So forecasting challenges affecting M&H supply include incomplete or delayed consumption data. So data gaps, delayed reporting, policy changes, rapid scale-up of intervention make demand difficult to predict. So with unpredictable demand, you may have inaccurate forecast. So when forecasts are weak or misaligned with budgets and procurement cycles, supply continuity is compromised. So the impact of forecasting on value for money, that is in the procurement, is if we forecasted too few commodities, we will end up making emergency procurements at higher cost. We'll have increased risk of stockouts or expiries, reduced supplier confidence, market instability, and we also experience missed opportunities to pool or plan the procurement in a very cost-effective manner. So just highlighting some of the approaches that we've used in Zambia, for example, we've leveraged on partnerships with UN agencies, in particular UNFPA, UNICEF, and UNDP, in the procurement of the M&H commodities so that we could secure the essential commodities even when there are market constraints. And this approach has helped ensure access to quality assured products, improve supply continuity, reduce emergency procurement, and also leverage match fund incentives. So, with the UNFPA compact agreement that was there, we were able to qualify for match funds, which were used to secure more commodities to cover the needs that we needed. So in terms of progress, and we really appreciate the partnerships that we have with these big organizations that are working regionally, there's also need to look within the region and see how partnerships can help in terms of allowing us to access value-based procurement. So at the regional level, progress towards food procurement within SADC, it focuses on data sharing. So we're sharing information on volumes and prices so that we have better bargaining power and also help us with forecasting and also better market visibility. And these efforts strengthen the region to bargain and lay the foundation for sustainable value-based procurement for M&H products. So looking ahead, how do we strengthen value in the procurement processes so that it is actually having the impact that it needs? We need to improve forecasting through better data and coordination. We need to increase transparency, as is happening in the region where information is being shared, and market visibility, expand the food procurement and regional collaboration amongst countries. And most importantly, the take-home message is, as we procure, we should anchor our decisions on the outcomes for women and newborns. Thank you.
Thanks very much, Rachel. You have moved us towards a model of value-based procurement and highlighted some of the challenges, and you will see the appreciation popping up on the screen from the audience. There's already a robust discussion taking place. Our panelists sit at different points in the ecosystem and at different levels in the ecosystem for procurement. Their biographies, as we mentioned at the top of the hour, are in the slide deck that has been shared with you. So I won't go too much into that. But as I introduce them, I would like them each to assess what you have presented here and point out critical barriers from where they sit, one critical barrier and one change that unlocks progress. They are Jacqueline Maine, who is Deputy Director of Customer Service at KEMSA in Kenya. Kenya has a devolved system of health. So from where you're sitting, what are critical barriers to value-based procurement? One change that unlocks progress before I go to the other panelists as well.
Yes, thank you, Spring, and good afternoon from Kenya. Yeah, this is Jacqueline Maine. For Kenya, one of the main barriers is really the procurement processes, and the first one is really the competition of resources, and this is the financial resources for procurement of M&H commodities. health in Kenya was devolved to the counties. So procurement of health commodities is not centrally managed. Funds are provided to the counties to do the procurement. Often there is limited resources, and with a lot of counties, and these are the 47 counties in Kenya, competing with other health commodities on allocation of sufficient health budgets, which then does limit dedicated funding for the MNH commodities. Other than that, there is also the procurement process, basically, which sometimes deter the implementation of the value-based procurement. As you're aware, KEMSA indeed does have a guideline. Kenya has a Public Procurement and Disposal Act 2022 that provides guideline on procurement, and the procurement process is supposed to be really fair, equitable, transparent, competitive, and cost-effective. However, the element of value-based procurement has not really been clearly it doesn't clearly come out in the Public Procurement and Disposal Act. However, there has been a lot of engagements with various partners, and Kenya is looking into implementing value-based procurement, which ideally would go beyond the price element, because most of the procurements are usually based on price, and other factors, of course, are considered, but it's always the last evaluated price. So just to mention.
Perhaps
Yes,
before we mention
sorry.
other issues, because we will collect a number, perhaps I could just bring in some of the other panelists. Patrick, you are a regional advisor at doing supply chain management in Western Central Africa. So we're taking it one step up from the national level. And that challenge that Jacqueline mentions of keeping cost in mind, but also then trying to assure value, does that apply to you, or do you find that there are other challenges in the supply chain that are more relevant?
Thank you. Thank you so much. I mean, it's really a great opportunity here to share, as you are saying, for the regional perspective. We see governments doing procurement, yes, of different services, but one of the biggest challenges is that it's the same public procurement law. So whether you are doing constructions or you are buying cars, you are doing huge projects, it's the same public procurement law, which is also applicable to health procurement. We've limited flexibility, of course, to really reflect the specific risk profile of the products. You may agree with me that a project can delay, but for childbirth, there's no much time to wait. So we should have the product there, the quality product there to save the baby and the mother. So one practical shift, I think, it's really to work within that procurement system or platforms to incorporate the value-based procurement, even without changing the rules, especially for the technical evaluation stage, to really re-emphasize on quality certification, to introduce the respected national regulatory systems as we do at UENE, past performance with the suppliers. I think one of the speakers before talked about the supply continuity, really to rely on those suppliers that can be more financial and technical capable to reduce the risk and help protect the continuum of care. That would be what I could say.
Yeah. So Christopher, at the PAHO, or the Pan American Health Organization Strategic Fund, sort of stands out as an example of one of the entities that has tried to address the questions or the challenges that Patrick and Jacqueline have both raised. So have you gotten it perfectly right, or are there challenges that persist to you, and what dimensions do you think we still need to consider?
Sure, thank you. Thanks, Spring, for that. So first of all, a very good morning, good afternoon, everybody. So greetings from Washington, D.C. So from our perspective, I would say one of the biggest critical barrier, and that's very much aligned to the theme of today's webinar, right, which is around fragmentation. And I think it's major fragmentation due to the lack of planning. And I would say I'll just start off and saying, and we can deep dive a little bit later on, I'll see that as four areas of fragmentation. First being the fragmentations of procurement policies and financing policies, which are not necessarily congruent to a nation or, in fact, classes of nations, sometimes clinical strategies, right, in that sense. So the second fragmentations, especially in the Americas that we've seen for the bigger countries, is the geographical fragmentations, where they are very much dispersed and decentralized in terms of planning, procurement, related to passing down to states, provinces, and municipalities. So geographical fragmentations in that sense. That results in small little tenders that doesn't accumulate to economy of scales in that sense. So the third fragmentation would be, I would say, around protocols, treatment protocols. While many different facilities and even sometimes within a country, a small country itself, between one facility and another facilities, between the Ministry of Health, between social securities, they have different treatment protocols, even for the same clinical outcomes. And that definitely unnecessarily drives complexities. So the fragmentations of protocols. And the last fragmentation, I would say, is really around quality and regulatory expectations between countries, which varies quite drastically, and that really impedes the speed of access of especially new technologies, new health technologies that's being introduced. So with that, I'll just close by saying that fragmentation, I think, in various areas that I just mentioned, the four areas particularly, actually can result in the fragilities that results in the outcomes that has been described by everybody, right, in terms of affordability, availability, assurance of qualities. So this will be very much the case. Thank you.
Thanks. I know you've summarized it very nicely. We'll deep dive in just a second, but before we do, I'm going to turn to our private sector actor here, Charles Kiveka, who is Director of Supply Chain and Logistics at AxMed. When you hear all of this, do you sort of recoil in shock and think maybe the private sector in health, you don't want to be involved in that? Or do you see opportunities to tackle some of those barriers from your perspective? And are there others that have been left out?
Yeah, thanks, Springs, and absolutely. Hearing the challenges and reading the room, absolutely see opportunities where the private sector players like AxMed could come in and help alleviate some of these challenges. One thing that came out clearly to me as I was listening to Rachel's presentation is where she mentioned one of the criteria for procurement. That's the lowest technically compliant bid. And looking at that, just those three words, lowest technical and compliance, in one sentence, brings to mind the aspect of enforcing compliance and quality assurance. And one of the approaches in the private sector is to ensure that we enforce quality assurance and compliance upstream, so that it's not part of the procurement process, it's not part of the creation. And in doing so, we reward manufacturers and suppliers who adhere to quality, so that at the point of our bid evaluation, and I'll come to that, it's about quality. We don't need to at the same time be evaluating quality, price, and technicalities. Second one is also how we embed this in how technology would become a play into this. We know with progression with technologies like blockchain, we can actually streamline and optimize the bidding process to make sure that we bring in more transparency. We avoid locking a quality bid on technicalities that could actually be captured on the upstream, on the quality assurance space. The second one, which also comes out very clear to me, and to a point that Christopher has spoken strongly around, is fragmentation and the supply chain execution. We know that economies of scale also apply to moving of products, and especially when we are buying products out of country, the shipping mode would very much determine how much the product costs. So with consolidated demand, with aggregated demand, we can actually be able to ship in bulk and choose more cost-effective shipping methods. So yeah, my take instantly would be on those two aspects and ways which we can solve this. Thank you, and back to you.
Thanks, Charles, very much. And let me come back to you, Jacqueline, then, because you are talking about creating a value product-based procurement guidelines for Kenya, where all of this is devolved and the risk of fragmentation is greater, not smaller, and the risk of difficulty in tracking quality or doing quality assurance is greater, not smaller. So how do we reconcile what you are facing as a challenge as a way to develop a solution based on what you've heard from the other speakers? What needs to go into your guidelines?
Okay, thank you very much, Spring. For Kenya to attain the value-based procurement, specifically for public procurement, because that is where KEMSA plays a big role. Firstly, obviously, we've taken a step towards, discussing on what would matter when it comes to value-based procurement. And we are looking at, of course, quality, has already been mentioned, supply reliability, and the long-term system impact. We have already come up with, proposed solutions to achieving this. And first and foremost is we are looking at development of product specifications by users to guide procurement entities on what to procure. So the user needs are being looked into. And there's an element of advocacy for value-based procurement procedures at the county level. And this is in the health facilities where price obviously still remains the big driver of procurement decisions rather than quality. So the aspect of advocacy of value-based procurement is also a proposal. And finally, I would say Kenya has already implemented e-government procurement. And this is actually to promote transparency and good governance in public procurement. The rollout already commenced in 2025. And it's ongoing, and government is actively training staff and suppliers on use of the e-procurement. Thank you very much. Back to you.
Thanks very much, Jacqueline. This question, I guess, is to both you, Patrick, and you, Christopher. First, Patrick, does what Kenya is describing here begin to address this question of non-differentiated procurement? You raised the question also of risk profiles. Does what Kenya is doing on product specification by user begin to answer some of that challenge? Is more needed?
Yeah, thank you so much. I think it really answers, but we really need to also focus on the source. I liked Charles' comment on not building the quality when it's too late. So I think having a pre-qualification system, for example, whereby only qualified suppliers will come and compete rather than just opening up to everyone, then you get from 100, maybe you get 90 that are not really good. So it will take more time to filter at that time rather than having a pre-qualification system as we do at EWENE. So in EWENE system, we do have some mechanisms such as WHO pre-qualification or relying on WHO listed authorities so that any of those suppliers, if they are already able to supply in those regulated market, then it's a good indication. But it's not stopping there. We need these higher risk commodities, we need to build up delivery performance inside. Is this supplier on time already? Does it help us to have fill rates that are consistent here? Can we also rely on his quality, so the reliability over time, so that we can have a good performance mechanism, or performance monitoring mechanism, so that we just keep them on check. The third one is the production capacity. As you are saying, I think Christopher also alluded it to, for new products where we don't have demand, we need to have assurance that this production capacity is going to be there. Otherwise, if the demand is peaking at a very unplanned level, so we need to have this supply sustainability built in that production capacity. So working more on the source side, of course, engaging the users to make sure that we pick the right product can help us, especially for fluctuation in demand. So the fourth one that everyone would just start saying, transparency and responsiveness. From simple things like ER communication, sharing information, taking these partners, these suppliers as our partners rather than just vendors. I think that building up of transparency and responsiveness can help us to address any challenge. So I know most of this time of procurement, there will be challenges, but the way you communicate each other, the way you share, the way you are transparent, the way you have intention to build up together, I think that can help to achieve this procurement. Thanks.
Thanks very much, Patrick. And over to you, Christopher, because you outlined the levels of fragmentation and the different kinds, and Kenya's trying to address that. But do they go far enough, or in your experience, is there expertise that you can give to guide them as they try to get to an optimal solution?
Sure, no, thanks. First of all, yes, I wanted to address one of the points which I think Charles mentioned about how this information can really help the private sector in terms of the planning and manufacturing, right? So I think it's important for this, and I think pool procurement plays a very important role. So especially it's definitely going to benefit countries with smaller demands, smaller countries, right? So in Americas, what we have seen is that through this pool procurement and collective planning, and we have facilitated over 35 countries in our region to plan together, right? Synchronizing their planning schedules and pulling all the demands and the requirements from all 35 countries. So as a result, that the smaller countries will also benefit from this economy of scale, all right? And with fairly robust and accurate sharing of and visibility of this demand is definitely going to help the private sector plan, not just in terms of their manufacturing capacities, their manufacturing timeline, and as what was mentioned as well, even from a transportation mode standpoint. I mean, mere transitioning from air freight to ocean freight, if planning is done properly, the cost of saving in terms of transportation costs could easily vary between 40 to 60%. So that actually makes a lot of difference. So I think in from an alignment standpoint, I think alignment in terms of planning calendar, budgeting calendar does make a lot of difference. So that's the first thing. And I definitely agree with what Patrick and also Jacqueline mentioned about quality, ensuring quality. I think the alignment of quality expectation is definitely very important. I think pre-qualification, no doubt, I think is a very universal standards, but we also have to acknowledge, I think there are many categories out there and health technologies that may not necessarily have pre-qualified suppliers, and we know that pre-qualification is a fairly long process and expensive process. But nonetheless, having said that, that's definitely by no means that's the first gold standards that we should look for. However, when it comes to categories of medical technologies and health technologies that may not necessarily have pre-qualified suppliers, I think it's also important as a region or as clusters of countries to have strong regulatory reliance and also harmonization as much as possible so that this pooling resources, because pooling of demand is not going to work if you have different expectations and fragmentations in terms of quality standards, in terms of regulatory pathways and so on and so forth. So I think for me, alignment and to some extent of harmonization of regulatory and quality standards is also key. And the last thing I would just want to say is definitely in terms of the synchronization of policies and funding policies, right, that is congruent to the clinical requirements and the burden of disease of the country itself. Because many times we've seen while forecasting is accurate, right? We know this is the amount of health technologies needed for the country to either control or eliminate a specific disease. But because the corresponding budget and funding sources is not congruent to what they are seeing and from an estimation standpoint, and therefore that actually still results in a shortage in urgent procurement being triggered and so on and so forth. So in that sense, I think there is a serious conversation that needs to happen between the Ministry of Health and Ministry of Finance to have this congruent policies of funding, financing, and a perpetual alignment there. Thank you.
Thanks very much, Christopher. And those of you who are from Ministries of Health and Finance, you can start having that discussion in the chat. There's already some robust back and forth. So we'll bring that into the discussion very shortly. But Charles, I just want to take again your view on if there's anything else that you need from the buyer side, any other signals other than what has been mentioned already, that then optimize for the private sector the interest in engagement and the interest in supplying for the maternal and newborn health needs.
Great. Thanks, Spring. I think very well articulated by the panelists before me. I would just like to double click on a point that Christopher just made around pool procurement and demand aggregation and how that drives efficiencies. So AxMed sits in the unique position where we have a two-sided marketplace. So we interface with both buyers and sellers. And what we know with the sellers and the suppliers of medicines is that they also have another supply chain ecosystem that exists for them, an upstream that means that they need to acquire APIs for the manufacture of medicines. They need to run through a whole supply chain process. And this is what makes predictable demand and forecasting very important for them. It also drives their capacity, because when suppliers have a predictable demand, when they have forecast quantities and predictable production cycles, they're able to utilize their production lines to capacity. And economies of scale as well come into play for production. It means that you can produce more units at a fixed cost. We know all about fixed overheads. So yeah, that's a great point. And something that really the private sector expects from public procurement agencies and the drug procurement partners. The other thing that's coming out clearly is the requirement of embedding technology. Technology is becoming more of an enabler as we progress. So into the procurement process, into how we procure, to help alleviate some of the challenges that Rachel mentioned in a presentation around predictability, around quantification. So yeah, those are two things I could think straight away. The third one, and also very important, is the way the private sector approaches the public health question. We know what comes to mind every time someone mentions the private sector is that profits are at the fore and expensive products. But more and more, we are seeing more private sector players coming with a private sector-based approach, but with a public benefit mindset into it. That's where we get global access prices to quality products. We get global access health units, and also, yeah, some of the models that are now created to enable our buyers acquire these products at the best possible prices. Cognizance of the fact that the private sector also plays a large part in alleviating some of the challenges that we know that happen in mother and newborn child health, and also in the public health sector. Thank you, and back to you.
Thanks very much. And Charles, you're just reminded this is being recorded and everybody's going to come to you now and say, you said that we're only doing global access prices and procurement with the social benefit and interest. But it is important actually for this sector to keep in mind that what we are talking about here are interventions that save lives and secure the development and progress of entire countries. Okay, there are a lot of questions in the chat. And so I'm going to just not attempt to summarize our discussion so far, but pose questions to you from the audience and then summarize the key messages that you have all shared with us. Thanking you very much for this very interesting panel discussion. My first question actually goes to you, Rachel, and I will read it out slowly. The question reads, I like your definition of value-based procurement, looking beyond price to total value, but how does that translate practically? The research and development push is still to get the lowest price feasible, while purchasers are still looking for the lowest price possible. So distinguishing between feasibility and possibility. How do we and I'm assuming this means those at the research and development end, message a fair, higher price that is overall better value. I think that's targeted at public sector purchases. So, Rachel, would you like to come in on that?
Thank you for that question. And really, if the panel mostly answered it as they discussed it, even in terms of the practical aspects of it. When it comes to messaging, we really need to be able to communicate the impact on mothers and newborn when we are not taking into consideration the value-based procurement. I think as I spoke about earlier, where if you get substandard commodities, you get unreliable suppliers because you're focusing more on the cost rather than qualifying the quality and the reliability at a beginning point of procurement. Then these are the outcomes that you get. So it's about messaging that, and everyone, I think, is looking at how do we keep mothers alive as they're giving life? How do we ensure that children are not dying? And that is part of the conversation to say it's not just about what our pockets can buy, but we need to assure quality for our mothers. And that communication needs to happen at all levels. And you need to bring in even the leadership. In terms of political leadership, don't underestimate, actually, in certain political environments, those are the people that you need to be talking to, because they are the ones that appropriate funds for the country. They are the ones that agree to say, okay, in for example, our yellow book as Zambia, we're going to have a dedicated line for reproductive health commodities. That comes from the messaging. And then establishing, I think, as one of the panelists spoke about it, doing it upstream from the procurement process, the issue of vetting the suppliers and vetting the quality, so that when you're evaluating the lowest, they've already passed that level of reliability and quality. That's the practical aspect.
Thank you. And to the remainder of the panelists, if you wish to comment on any of these questions, please just give me a signal. I will pose them to one person, but if you think you would like to add, please, we welcome that. This next question, well, it's actually two questions that are bundled, and they go to market shaping. So I think maybe, Charles, I'll pose these to you. From a market shaping perspective, innovative access agreements such as the Pfizer Accord or pooled digital platforms like AxMed can potentially improve affordability and supply reliability. How do we reconcile these models with procurement rules that require open and fair tendering? And are there examples of hybrid approaches that preserve competition while still enabling long-term value-based arrangements? Charles, do you want to give that a first go?
Sure, yes. Thank you, Spring, and it's a great question, and it's one we get in most of the rooms that we walk into to share this idea of technology-based enabled pool procurement and how that aligns with, for example, in my own country, the PPDA, the Public Procurement and Disposal Act, and the PPRA, the Public Procurement and Regulatory Act. So two things I would say to this are, first of all, with the enablement of technology, we can actually look to fulfill the same criteria that our public procurement and tendering agencies put out there for the traditional and conventional procurement system. And how do we do this? It's been said in this forum more than once about the upstream supplier pre-qualification, the quality the compliance enforcement upstream. That means, like, for a procurement platform like AxMed, we pre-qualify anyone who comes onto the platform, any bids you'll see on the platform for pre-qualified suppliers, and you will be able to access their credentials, WHO, PQ, SRA. So we do that as upstream. We only provide the buyer with suppliers we've pre-qualified. The other thing is now even the procurement agencies operate as regards to opening bids, specified timelines for submission and opening bids, and all these are possible with a technological backbone to the procurement process, where we can stipulate when bids will be open. We can stipulate who gets to submit a bid to completion, so that we have the checks are even embedded in the bidding process, so that we don't have these challenges that occur in the traditional procurement cycle, where you evaluate all these bids and then you get to disqualify some bids on technicalities that could have been picked up along the procurement process. So yeah, just those two things. Yeah, the pre-qualification and the technology embedment into the process. Thank you.
There's a follow-up question, and I think this maybe I'll pose to the two large procurers here, to Christopher and to Patrick. Christopher, maybe you first. There's a question about, well, isn't that unfair to new actors coming into the system? You know, if we're always going with pre-qualified, existing, known vendors, what about people who would like to enter into this field? And then there's a related question about, can there be more legislative approaches taken, like considering tax exemptions for critical commodities or price caps? Are there countries that do this already, and is there something we can learn from them?
Thanks for the question. I think that's a very valid question, and obviously we do not strive for monopolies, right? And definitely, I think if we're just, especially when I mentioned earlier on in terms of pre-qualification suppliers, while we say that's really the gold standard, and I think that eases in terms of quality assurance right from the onset. However, having said that, especially for us in the Americas, and I'm very sure in the other regions around the world as well, having gone through the pandemic itself, we have also understood the importance of supply resilience, and is not to be concentrated geographically. And therefore, as a result of this, many of us are thinking about regional manufacturing and the diversification and decentralization of manufacturing capacities around the world that is closer to shore for us as well. And therefore, we are also in the process of capacitating and working with WHO, of course, capacitating regional and local manufacturings that is closer to shore, and aiding them and capacitating them towards, pre-qualification, if not at least bring them up to the standards of, WLA, WHO listed authorities, so that they can be sufficiently equipped with the quality standards to provide to regions or countries that's nearer to shore. And that's really the results of the pandemic itself. So I would say a lot of emphasis has been given to local and regional manufacturers. They're not necessarily at this current point in time pre-qualified, but that is really, I think, the part of the global strategies to really not having geographic concentration from a manufacturing standpoint. And I just want to quickly take the opportunity to address the earlier question around the R&D portion, right? I think it is also important for researchers to think about, I would believe that most national regulatory agencies would have introduced this concept of HTA, Health Technology Assessment itself. So we really do not hope that there will be too many people looking into invention for creation's sake, right? With very small incremental differences. That's why I think there's a lot of emphasis given into health technology assessment, right? To understand now what are the added value in terms of, be it DALI, so disability adjusted life years, quality adjusted life years, indicators of this new product that's being introduced into the market. If it doesn't add sufficient benefits, be it in terms of clinical outcomes, in terms of cost effectiveness, then obviously I think countries are not going to be adopting it, because they wouldn't see the value of introducing a new technology that do not have sufficient outcomes, better outcomes as compared to alternatives. And that would actually just simply add on to more fragmentation that I just spoke about earlier on. Thank you.
Thanks very much, Patrick. I don't know if you wanted to come in and add anything to that from your perspective.
Yeah, I just wanted to add something that maybe we are not really clearly mentioning, because this is a relationship between a seller and a buyer. And I want to bring the ingredient of trust both ways, by the way, because if we have to trust our suppliers, they also have to trust us. So any agreement in terms of payments, in terms of treatments, I mentioned early transparency. I think we should not see one side that is very perfect. We, the buyers, the government, the other side. But also, I would imagine if we have someone here from the industry, they'll maybe mention other challenges from their side. So if we treat this as that relationship where we build trust, I think everything can go well. So if we treat them as our partners rather than just single vendors coming to for businesses alone, we will be failing. So I'm just putting it up here because I know so many suppliers are maybe the payments is defaulted, then the next tender they are going to build up those risks. Then you get either high cost or lower quality because you are not trustable as a partner, as a buyer. So we need really to build that angle of trust. And for people asking, do we go for, even if it's value product, do we go for a high cost? No way we can spend the monies that are from our member states or our donors the way we just want. So it's more, you get good suppliers, yes, but then the cost is critical. We need to get more with less. So there's no way we can just spend for spending. So the cost will always be determinant at the end of the day. Thanks.
Thanks. I mean, you're speaking to responsible stewardship, not just of monies, but of relationships. And I think that's an important point to bring out. There are so many questions in the chat, and we have 4 minutes left of the discussion. So please forgive me for using my discretion to just pose 1 or 2 more so that I can also respect your time. This next question goes to you, Jacqueline and Rachel. And there are 2 questions. The first one is, value-based models scare me a bit as they have been used by industry to justify extremely high treatment prices on the basis that they are life-saving. Are the two reconcilable? That is value-based procurement and value-based pricing. And then could you apply that question to, in particular, effective planning based on preferences for family planning products? So I don't know who wants to go first. Jacqueline, perhaps I'll turn to you.
Okay, thank you, Spring. Yeah, all the questions are really very good. Yeah, so the aspect of value-based procurement and how does it reconcile with the various procurement laws that exist? I'll speak to the Kenya case example. As I said, we have the Public Procurement and Disposal Act. When it comes to how the value-based procurement can be a good example in terms of perhaps even what we have been able to implement, I'll speak to public and private partnerships. I have 2 examples of 2 products that we've been able to procure as an example of value-based procurement at KEMSA, and this is for heat-stable carbetocin for mothers and caffeine citrate, and this is for neonatal health. And this is basically procured through access pricing, very low pricing. For example, the price of heat-stable carbetocin, we've been able to access it at below $1 in comparison to the market commercial price of around $20. And the law in Kenya provides for a justification to be able to combine value with price. And that is a classic example of how you can still comply with the procurement guidelines, but also providing a product that is of value and of quality to the market. Thanks. I think that's what I would want to say for now.
Thank you. You got claps from the audience for that. Rachel, I don't know if you want to add anything.
I think I just wanted to add on the planning portion, in effective planning. At the beginning of every process is the selection of the commodities, and every country has to make sure it has in place committees and committees of experts that do the selection, and the selection is not just based on what's new, but there's a whole comprehensive list of what is looked at. So, for example, in Zambia, we have the Zambia National Formulary Committee. So even as pilots of the heat stable carbetocin has been happening, we've had the projects have to make presentations to a formulary committee, which is made up of various experts, including procurement and central medical store experts, to vet and also to ask the questions to make sure that even as decisions are made to add certain products and include them in the forecasting and supply planning, we would have looked at the cost, the overall cost, and also the benefit. And once it's part of the selection, again, it's always important for the team to ensure that we plan our forecasting activities, and also ensure that even the procurement processes are planned. So even by law, as a regulator, the central medical stores has to submit a procurement plan, which indicates when a procurement process is supposed to start and when, so that you have a proper plan of when commodities can come in, ideally. Thank you.
Thanks very much. My audience, I'm just going to take 1 more minute of your time to attempt to summarize. And let me first begin by thanking all of our experts, because we thought that there might be a great diversification of views about what is needed. In fact, you are so aligned. You are aligned on what the challenges are, on fragmentation, on quality assurance, on where in the process you locate what in order to ensure access for mothers and children. You have clearly defined for us a common understanding of what value-based procurement is, and your interventions show that a lot of thought is going into how you define value beyond price in a very practical and person-oriented way. And to also working on moving efficiencies as far upstream as you can so that access at the end of all of the process is not impeded. There are persistent bottlenecks, lead times, delayed payments, fragmented tenders, weak forecasting. But all of these, you have said, are solvable with better governance, with transparency, with relationship building between the purchaser and the seller, treating each other as partners and not just as vendors or purchasers, and then embedding technology as an enabler. So you're looking beyond your own place in the ecosystem to what else is out there to improve care. You're taking very practical approaches to accelerating progress through pre-qualification, health technology assessment, pool procurement, harmonization of specifications, trying to build supply resilience and nearshore access, diversification and decentralization. And we didn't discuss very much, but also you talked briefly about incentives to reward performance. So thank you for all of that. Thank you to the audience for your excellent questions. We unfortunately could not get to all of them. We had 275 of you with us here, so there was going to always be a challenge. We look forward to continuing to build this practice, this community of practice. We will share the materials and next steps. Please do join us or stay tuned for our upcoming webinar on how to pay for it all through innovative financing. We will look at blended finance, public-private partnerships, and other procurement incentives to secure sustainable financing. For now, thank you to our hosts and organizers, to our experts, and to all of you for your time. Bye.